Simvastatin in the acute respiratory distress syndrome.
Studies in animals and in vitro and phase 2 studies in humans suggest that statins may be beneficial in the treatment of the acute respiratory distress syndrome. This study tested the hypothesis that treatment with simvastatin would improve clinical outcomes in patients with ARDS.
Hi, this is your pharmacist from Pharmacy Republic. Today we'll be talking about simvastatin. Simvastatin belongs to a class of drugs known as statins. Statins help to lower your cholesterol. Simvastatin is available in a number of different strengths, including 10 mg, 20 mg, 40 mg, and 80 mg. It is best to take simvastatin at night, since this is when the most cholesterol synthesis occurs in the body. You must remember to avoid taking simvastatin together with grapefruit juice, since this can lead to increased levels of simvastatin in the blood. Common side effects of simvastatin include muscle weakness and pain, and can eventually lead to a condition known as rhabdomyolysis, which means muscle breakdown. If you experience any muscle weakness or pain when taking simvastatin, contact your doctor immediately. Okay, that's it for today. See you next time. Bye.
In this multi-center, double-blind clinical trial, we randomly assigned patients with an onset of ARDS within the previous 48 hours to receive enteral simvastatin at a dose of 80 milligrams or placebo once daily for a maximum of 28 days. The primary outcome was the number of ventilator-free days to day 28. Secondary outcomes included the number of days free of non-pulmonary organ failure to day 28, mortality at 28 days, and safety. Recruited 540 patients with 259 patients assigned to simvastatin and 281 to placebo. The groups were well matched with respect to demographic and baseline physiological variables. There was no significant difference between the study groups and the mean number of ventilator-free days or days free of non-pulmonary organ failure, or in mortality at 28 days. There was no significant difference between the two groups in the incidence of serious adverse events related to the study drug.
About acute respiratory distress syndrome, otherwise known as ARDS. Now, acute respiratory distress syndrome is a disease of lung inflammation, and the inflammation leads to a cascade of events that leads to lung injury. Now, there are a number of different things. The lungs are very prone to injury for a number of reasons, and I'm going to get at that as we talk through this video. Now, the lung inflammation is really centered around the nexus between the capillaries and the alveoli and the thin membrane in between. So this is really a syndrome of inflammation of the pulmonary alveoli and capillaries. Now, it can be caused by a number of things. So causes or predisposing events. One possible cause is that there is injury to the alveoli. Now, it could be injured by chemicals, like smoke inhalation. It could be caused by severe burns to the tissue, if the person was in a fire and breathed in hot gases. It can be caused by infection, where we have little bacteria and a buildup of pus with injury to the alveolar epithelium. Or it can be caused by the inflammation can start in the capillary side. Now, what's interesting is if you have inflammation somewhere else in the body, so let's say we have a person, this is a gut here, person's gut, and they have ischemic gut because they have a, the vessel supplying their gut has a big atheroma or an embolus, and it clots the gut off, the blood supply off to the gut, and we end up with ischemic gut. What's going to happen? Well, cells are going to lyse and die, and they're going to release lysosomes into the blood, into the venous supply, and the tissues are going to become very inflamed because of the ischemia. So we're going to have lysosomes, and we're going to have cytokines from ischemia. And where's it going to go? Well, it's going to go up to the right side of the heart, dump it to the right side of the heart, and then from the right side of the heart, it's going to get pumped to the lungs, right? And all of these inflammatory mediators and lysosomes from lyse cells and high concentrations of potassium and all sorts of other things, this sort of nasty inflammatory brew, is going to get pumped relatively rapidly through the large vessels from the heart, and then they're going to slow down in the capillaries, and these are going to start interacting with the sensitive endothelial cells inside the pulmonary capillaries. So the lungs are sort of the first stop as blood returns from injured cells throughout the body. So the lungs are very prone to inflammation spreading to them from other organs in the body.
Patients received the study drug for a mean of 10.2 plus or minus 7.1 days in the Simvastatin group and 11.0 plus or minus 7.9 days in the placebo group, p equals 0.23. The most common reasons for discontinuation of the study drug were discharge from critical care, death, and an adverse event that was considered to be related to the study drug. A total of 5 patients assigned to Simvastatin and 3 assigned to placebo received treatment with non.
Statin, a generic brand of Zocor and one of the more popular cholesterol-lowering drugs, last summer was issued a new safety recommendation for dosages over 80 milligrams. The FDA warned of elevated risk of muscle injury or myopathy, saying it should not be prescribed to new patients.
The statins in general, and simvastatin in particular, often cause muscle aches, muscle pain, and ultimately it could be fatal. And that occurs when the muscles are so inflamed that they actually break down, and the muscle contents get spilled into the blood, and they go to the kidney and cause kidney failure.
Zussman said physicians have known about the potential side effects for over 20 years, but the Food and Drug Administration did not release its warning until this past June, and many patients didn't find out until they were notified by a pharmacy. Team 5 Investigates obtained this CVS letter to customers with the FDA warning of increased risk of muscle damage and myopathy that could cause damage to the kidney and kidney failure, which could be fatal. Zussman said while that is very rare, patients should not ignore muscle numbness and they should contact their physicians before altering their regimen. Zussman said Simvastatin has never been his first choice of cholesterol-reducing drugs.
Conclusions.
Simvastatin therapy, although safe and associated with minimal adverse effects, did not improve clinical outcomes in patients with ARDS.
Welcome to the next installment of Critical Care Survivor Guide. This time we're going to be talking about ARDS, or the Acute Respiratory Distress Syndrome. ARDS is defined in 4 ways. The first is bilateral infiltrates on a chest x-ray, as shown here. The second way we define ARDS is by looking at the PaO2 to FiO2 ratio. This ratio tells us how severe the disease is. If the ratio is between 200 and 300, we have mild ARDS. Between 100 and 200 is moderate ARDS, and anything less than 100 is defined as severe ARDS. The third criteria we look for in diagnosing this syndrome is a lack of heart failure. That means that there is a low pulmonary capillary wedge pressure less than 18, or a low central venous pressure less than 8, or a low BNP. It's also acceptable to use standard clinical criteria such as clinical exam and imaging to help to rule out left heart failure as the cause of the bilateral infiltrates. The fourth criteria for ARDS is that we need a reason for it. This might be secondary to pancreatitis, or more commonly secondary to septicemia. The list of causes of ARDS is shown here. Our approach to the patient with ARDS consists of maintaining low tidal volume ventilation. This is extremely important. Good studies have shown that if we provide too high a tidal volume or too high a pressure into the chest of a patient with ARDS, we'll make the disease worse. So we follow these ARDS-NET guidelines. They include starting ventilation at low tidal volumes, that being 6 milliliters per kilogram predicted body weight. The way we ventilate patients with ARDS is based on their height, not on their weight. It's important to recognize that we're not going to be setting the tidal volumes based on the patient's weight, but rather we'll need to know their height. Next, we'll use higher PEEPs, positive end expiratory pressure, in order to help oxygenate these patients. PEEP is a mechanism we use to achieve better oxygenation through not only recruiting more alveoli, but also enabling oxygen molecules to stay next to the capillary interface longer inside the alveoli. After we've set up our ventilator properly with ARDS, the next thing we want to pay attention to is fluid status. So long as the patient is not hypotensive, it's appropriate to try therapy with diuretics. We believe that patients ventilate better and oxygenate better when their lungs are dried out, so to speak. So it's okay to use diuretics and follow the central venous pressures in patients that are not hypotensive with ARDS. Finally, patients that have progressed into severe ARDS sometimes require rescue therapies. These come in many different forms. You'll see different forms of rescue therapies at the different hospitals here at Indiana University. For example, at Wishart Hospital, one of our rescue therapies is the oscillator, shown here. Oscillatory ventilation works through very small tidal volumes set at a constant pressure inside the patient's chest. Additionally, at Wishart and the other hospitals, we have rotoprone therapy. A rotoprone is a special type of bed that turns the patient onto their stomachs. This works to achieve better VQ matching and improve oxygenation. At Methodist Hospital, we have inhaled nitric oxide. That improves blood flow to the oxygenated alveoli. And finally, at Methodist Hospital specifically, we have ECMO therapy, which, as you'll learn about, is a rescue therapy using a gas exchange membrane external to the patient. Sometimes we use ECMO to bridge patients to lung transplant. Other times we use it to help them survive ARDS. So in conclusion, ARDS is a common syndrome that you're going to see in the intensive care unit. It typically involves 4 things to make the diagnosis: bilateral infiltrates, a low PaO2 to FiO2 ratio, a lack of heart failure, and a good reason. It's important that we manage their ventilator properly, consider diuretic therapy, and know when to employ rescue therapies.
Ultimately, you do not reach for